Good morning, everybody. And it's good to see everybody here. I'm going to try to address different issues that have been coming up in OB, especially in 20 years of practice. It's amazing on how OBGYN medical care has changed so much. And I would like this to be more of a conversation. So if at any point anybody wants to interrupt me, ask a question, clarify, please do. I mean, this is more of a conversation on especially all the current events going on. So who we are, this is my awesome Catholic healthcare team. Of course, myself, was called NFP only since '99. Maggie Schoonmaker, who's also in the back, is my fertility educator. She just finished training for lactation consulting and as a doula. So through our office, we're able to offer more services. We teach what's called Billings ovulation method. It is a mucus-only system of women learning their fertility, and I'll talk about that a little bit later. Maggie's been with me since '99. Which has been a long time, but it's just been such a blessing that we've really helped women for getting pregnant, not getting pregnant. It just has been a joy to work with her. Annie is our newest addition and my tech person, who unfortunately is not here with us right now. She's a physician assistant, and those who don't know, I am going to tell a little story about Annie. It's kind of cool how she started to work with me. So as everybody knows, between my husband dying 6 years ago, working a busy practice, and trying to homeschool my son, I was just really kind of stressed. What am I going to do? How am I going to keep all this together? So I am at Adoration Chapel praying, okay, God, what am I going to do with Michael? I'm trying to keep everything together. And he kept telling me, you need to homeschool, you need to homeschool. And at that time, I'm like, really? I don't have time to homeschool. I've got a busy practice. I can barely take care of myself, much less anything else. And at the end of the hour of praying, I'm like, okay, fine, whatever. If that's what you want me to do, I will get it figured out. Of course, me figuring out, that's not really what happens, but that's what I'm thinking. So at my office the next day, I have a resume on my desk for a young lady who is finishing becoming a physician assistant. She went to the same school that I went to, and she wants to work in a practice that is Catholic identity. And I'm looking at her resume, I'm like, seriously? This is so easy, thank you. No, I mean, well, you know, it was interesting. I knew I needed help. I just didn't know how I needed help. So I'm going through a resume. I'm like, wow, I can have help in the office, and then maybe I can homeschool. So long story short, I called her, we clicked, and she's been working with me since June or July. And she's just been awesome. Patients have loved her, but it's been easy in that we're ethically, morally on the same page. So she's like a mini me. So I can be off doing a delivery. She can see my patients. We're on the same value page on how we take care of our patients. And the beauty of our practice is it's just not taking care of them medically, it's the whole person. And how I look at it, it is my calling to, it's an honor to take care of patients. They allow us to take care of them. We want to do the best we can and give them all the information we can and take care of them as a whole human being, spiritually, emotionally, their family, and of course on their OB stuff. And that's what the beauty of our Catholic healthcare is, just not taking care of a medical diagnosis. And it's just not one issue. And I can't tell you how many times people come in, oh my gosh, I never thought this was going to be a problem. And you did tell me way back when, and now I understand, and now I want to do something else a little bit different. So it's really been an interesting progress in the last 20 years of just seeing our patients grow with our practice also. But Annie's been an awesome addition. So I guess that's my little plug for my PA, that sometimes God just waxes over the head and says, here, I'm going to help you because obviously you're having issues. So that was God helping me out immensely. Anyway, so Annie came up with our mission statement. Never thought of needing a mission statement, but our mission statement: to offer authentic, modern, and life-giving women's health care that is aligned with Jesus' teachings in order to promote healthy women, strong relationships, and joyful families. So that's really what our goal is, to look at the big picture of taking care of our ladies. So what is Catholic health care? And so this is kind of a summary of the Catholic directives. I do have a copy, thanks from Monsignor Meridian, on some of the OB issues. But what is Catholic health care? Dignity of the human person, a right to the means for proper development of life, adequate health care. Care provided should assist those in need to experience their own value and dignity. And that's what I really see as important for OB. Culturally, we're so into a materialistic society that everything has either got a purpose or it's materialism, is what I want, and it's that whole selfish of looking at things in a different way, whereas Catholic healthcare is really looking at their own value and dignity and the sacredness of life from conception until death. Natural law, and I'll be honest, when I was going through residency, I didn't really even know what natural law is, but it's really, everything has a purpose and a place, and things are used for a certain reason, and the way God made everything is perfect, but it's really celebrating all of those gifts, but not trying to make them unnatural either. And I wish I could give a good example. I don't know, Monsieur Meridian, if you have a good example of natural law.
Just like love, we're meant for
Love. We're meant for love. Perfect. All right.
Spouses, children,
So
a good example.
that works as a good example. Thank you. Teachings understood in light of the revelation of Christ has entrusted to his church. And then also with Catholic healthcare, faith and science are intertwined. They do not contradict each other. They really don't. And they're both are grounded in respect and truth and freedom. So a key player in healthcare, so preparing for the talk more so for Waterloo than here, is I had to do a little searching on for myself on how much Catholic healthcare has impacted our whole world environment. So interesting, the Roman Catholic Church is the largest non-government provider of healthcare services worldwide. Manages 26% of the world's healthcare facilities, 18,000 clinics, 16,000 homes for the elderly and those with special needs, and 5,500 hospitals. And 65% of those are located in developing countries. And with healthcare, 1 out of 6 patients are served by a Catholic healthcare system, which is pretty amazing. And what it didn't list on Wikipedia, and I think Trinity would probably fall in this category, there are a lot of hospital systems where there was mergers. So I don't know if those numbers actually count those mergers where part of the healthcare history has been Catholic in the past. When does life begin? So this is interesting, especially with our current events. I know you've all been paying attention to the media. New York is now letting babies that survive abortion still go ahead and get killed. And you get into when does life begin? Conception, implantation, heartbeat, viability, birth, 2 months after birth. 2 months after birth has been proposed by Peter Singer, is he a theologian? I don't know what he does. He's an ethicist or some job at Harvard or Yale or one of the Ivy League colleges on the East Coast. So why I'm bringing this up, conception. Obviously the Catholic Church, on the next slide will show, has always been conception. That doesn't change. Sperm, egg get together. That's unique genetic material. Nothing changes. You know, the chromosomes of a human being are not going to turn into a goldfish. We're not going to turn into a hamster. We're a human being. Nothing changes. And that comes with natural law too. You can't actually change that. You can't change those chromosomes and make a human being into something else different. So conception is pretty straightforward. Implantation, so interesting, medical textbooks in the 60s, prior to 1960, used to be life began at conception. It was agreed upon everybody. There was really no discrepancy. But once they started looking at the birth control pill and the different chemical contraceptives and doing all the research, they found that one of the actions of birth control pill actually, 3 actions. It prevents ovulation, it prevents implantation, and it gunks up the cervical mucus. But because the one action of preventing implantation, that if everybody legally, morally, ethically agreed life began at conception, that we need to change the definition of life. So a lot of textbooks now, or not a lot, pretty much all textbooks in medicine after the 1960s will say life starts at implantation to get that workaround of when does actually life start, so that they could approve the pill and other hormonal contraceptives that it would prevent implantation. So when it was being approved, abortion was illegal in our country, obviously, prior to 1973. So docs would say, well, no, it's not, a pill's not abortifacient or a devil's not abortifacient. Life doesn't start till implantation, so it doesn't matter. So it's interesting how the definition of life has actually changed with that. And then with some of the different states with heartbeat, you know, when does life begin? Does it start when we have a heartbeat? Does it start with viability? But as anybody that's OB knows, Dr. McDivitt, whenever retired OBs, you know, when you started practice, if a 28-week gestation lived, that was a miracle, or a 32-week. Now we're having 22 weeks survive. We're actually trying to do interventions to help these little tiny preemies live. When I started work, 24 or 26 was a miracle. The fact that we're even talking about a 22-week. So saying life begins and you're starting to use it viability, again, that is a moving target. How can life can be so arbitrary as being with a moving target with that? Birth. So current law right now in some of our states saying, okay, when baby's born, if it was meant to be terminated and it's still alive, then it's still okay for us to kill the baby. So is birth at the definition of life, and we're at on that birth, that first hour, first couple hours, how long? And then, of course, bringing up Peter Singer, the 2 months after birth. Where's that slippery slope? Where is that going to end? Is it going to be when the kid's rational at 8 years old? Europe with kids going through, they're terminating kids. What's the terminology? Hospice, euthanasia. They're euthanizing kids that have medical problems in Europe and it is legal. So if a family has a kid that's severe mental retarded, or I know not politically correct, cystic fibrosis or some bad medical disease, the parents can elect to have their child killed if they don't feel that that life is viable. So when does life begin? Is it when the parent decides that that child's is worth living? So it's just something we're thinking about culturally on where we're on that slippery slope and how far are we going to go? When does it end on the other side of life towards our seniors and end-of-life care? So just something that I think we need to always be cognizant of what's all going on. And Catholicism is consistent. Definition has always been a conception. And so, and of course, priest or Monsignor can help me. The saying of the Bible, when I knew you when I formed you in the womb. Conception. So, I mean, we have even biblical references. So right now, it's amazing, again, 20 years I've been in practice on how our culture has changed so much. Who would ever think that we'd be talking about when is it okay on terminating and having kids being euthanized? And, you know, people in the past would assume that if you went to a Catholic hospital, they knew what that meant. They knew what the health care they were going to get. Now it's changed. And the average person on the street, there was I'm going to digress a little bit. There was a movie about 10 years ago, Super Size Me. Did anybody ever see it, about McDonald's? And they showed a bunch of 5-year-olds, different pictures. Jesus Christ, Ronald McDonald, like a famous actor, all this stuff. The kids all recognized Ronald McDonald, but they didn't recognize Jesus Christ. So I bring that up, and this is from a movie 10 years ago on how we really are in a post-Christian world, that Christian values, a lot of average people walking around the street really don't know what that means anymore. And so part of our job, too, is just showing our patients how we love them as a whole person of who they are. And not necessarily, we're not evangelizing the office and we're not, you know, pushing faith at all. That's not what I'm talking about, but really just loving them as a whole human person. But they don't really get that in our culture. Our culture is, if you don't have so much money, then you're not allowed to do this, or they're just pegged in certain ways, where if you're public aid, so what? We're still going to give you the best care that we can. It doesn't matter. But anyway, our post-Christian society is so different now than what it was 20 years ago, or even 50 years ago. It's changed significantly. And our secular belief system has definitely changed. It's not the same Christian values that our country was founded on. So it's a lot of changes, and in healthcare it's changes because patients aren't sure what to expect sometimes when they see us in the office, and we're trying to address all their issues, not just talk to them about one thing. Women's healthcare challenges. So I'm going to touch just briefly, because I could go on and on, as you guys know, probably all day long if you gave me the time. As OB, so obstetrics, gynecology, reproductive health, emergency medicine. And this is more of just, kind of the topics and the issues that I'm dealing with, and healthcare is dealing with in general. Okay, so OB. This is the biggest issue. And kind of on a daily basis. I'm going to talk on each one. If anybody has any questions, concerns, please stop me and we'll talk. I really do want this as interactive as possible. Abortion goes without saying. So abortion is any time we do any procedure that would take the life of a baby intrauterine. So that could be pre-viable, it could be post-viable, the way our current culture is. And obviously with our Trinity Medical Center, we're not doing abortions. Abortions are done at a lot of secular hospitals, they're done in a lot of clinics. Currently in the Quad City area, thankfully, we do not have anybody doing abortions. I don't believe any of Genesis is doing abortions. The old Planned Parenthood clinic, as you guys know, is all closed. There are some places that will do some telemedicine or like the abortion pill, but that's another subject. So abortion is an issue. And in a healthcare setting in the hospital, like I said, very rarely does it ever come up that somebody says, okay, well, I'm pregnant, I don't want to have a baby, will you do an abortion? I do get asked that a couple times a year, not very often, thankfully, but the same thing on those cases. We just tell them, this is still a human being and this is your child, regardless of how things conceived. Because we are more of a multicultural area, we get this from a lot of our patients from other parts of the world. They'll say, no, but I need a referral, No, we're not going to do that. Let's do an ultrasound, let's talk about this baby. And that they still want to do anything on their own, they do that. They could do that, obviously, but I'm still not going to refer. But we do talk to them the sanctity of life, and we have some interesting conversations. Selective reduction, again, this is not done here locally. For those not OB, a selective reduction is when a woman goes through infertility treatments and she has more than one baby, anywhere from 2 to however many babies with either IVF or ovarian stimulation. And ACOG, unfortunately, American College of OBGYN, is very I'm not necessarily pro-abortion, but they really want the mom to have a healthy pregnancy. And so with all the research, moms that have fetuses more than 3 on up, it is harder to maintain that pregnancy for full term. So they do advocate what's called a selective reduction. So if somebody's gone through infertility and they have 3 fetuses, 4 fetuses, they will actually selectively decide which babies to terminate so she can carry the rest of the pregnancy. It's still heartbreaking, and I can't imagine the parents having to go through that. So when we do have patients who come through our office and they do go through any of the artificial reproductive technologies, we do talk to them that if you're going to do this, these are some ethical concerns that might come up. You need to be prepared to know how you're going to answer and having as much control as you can. So if you do IVF at Iowa City, ask for only 1 embryo or 2 embryos to be put in. Don't let them put in more. And they've gotten much better about that. But even if they're doing ovarian hyperstimulation and they have 8 eggs potentially that could be fertilized, we'll say then don't do the cycle. Cancel the cycle. Wait till it's something more manageable. Because if you do get pregnant with 4 babies, how do you decide which one you're going to terminate, or how do you let somebody else terminate? So a lot of these really complex ethical issues that even though we don't refer for IVF, we do have patients that go through that. We try to have them as prepared as possible on trying to make the best decisions and letting them know you don't have to do everything the doctors say. You know, if they're saying we're going to put all these embryos in, it's okay to say no. Or if we're going to make so many embryos in a petri dish, have control of what's going on. Don't let them make 20 embryos. Are you going to really implant 20 embryos in the future? So now we have all these embryos frozen on ice, and that's a whole nother issue. But that's what selective reduction is. And I'll be honest with you, even taking care of patients that have gone through it, just in my heart, I'm always saying prayers for them because it just breaks my heart knowing that these babies that are being born had a sibling that didn't make it. And I don't know, it's hard. Ectopic pregnancy, so as being an OBGYN, pregnancies are usually in the uterus, as everybody knows. But every once in a while, 1 out of 200 pregnancies, there will be a pregnancy that will be elsewhere, in the cervix, in the fallopian tube, on the ovary, on the omentum. So an ectopic pregnancy is a pregnancy that is usually non-viable. So we do need to take care of Catholic health care, and this is one. I am not an ethicist. I'm not going to pretend to go through all the nuances, but the majority of ectopic pregnancies, by the time we diagnose, the baby is already deceased. So at other times we have to take out the tube or try to take out the pregnancy from the tube. What comes into one of the interesting ethical stuff is you have a live gestation in the fallopian tube. There's another medicine available called methotrexate. Methotrexate is a cancer drug that will actually basically dissolve the pregnancy tissue, so that allows us to keep the tube. But there's been some discussion with Catholic ethicists, is it okay to use methotrexate? And even ACOG will say methotrexate is not as useful with a live heartbeat, so they do recommend surgery. So actually ACOG and Catholic healthcare is on the same page, but that is one of those dilemmas because the methotrexate purpose is to kill the baby, so or to destroy the dividing tissue. So again, a lot of ectopic pregnancies, by the time we see them clinically, the fetus is already deceased, but the placenta is still growing. So then we'll try to save her tube. So that's an interesting topic that comes up a lot. PROM, PPROM, premature rupture of membranes. This is one that a lot of times, not even just at Catholic hospitals, but there will be ethical consults everywhere. Most healthcare institutions where a mom comes in, her water bag broke at 14 weeks gestation, 18 weeks gestation, 24 weeks. And then how do we manage? You know, as she loses fluid, how do we actually manage that? I've been very fortunate in the cases I've handled, and it's been a handful that I've never had to terminate any of those pregnancies. We've given, you know, very careful counseling to the mom on there's always a risk of infection, there's always a risk of baby dying, but I've had, I guess my most crazy one was at 14 weeks, ruptured membranes, and she went on to 34 weeks and delivered a baby, and baby's doing okay. And so all the naysayers are like, there's no fluid, baby's not going to have lung development, or baby's not going to do good, you need to terminate, you need to terminate. So everybody's all this push for her to terminate, but she was compliant, she bed rest, we watched white counts, she never became infected, we watched her closely. And so baby's had, you know, some, you know, joint mobilities that she's working with physical therapy, but she's 4 now and walking and doing good. But if she had been cared for elsewhere, she would have really had that push for terminating. Now she has this beautiful daughter named Annie, which is just, she's the cutest thing. But with that, that's an area where, let's say somebody is ruptured membranes, but then mom becomes infected. Let's say bad stuff is going on. Sometimes it's kind of touch and go. You know, is she early infection? You don't want to wait till she's so sick that she potentially could die, but you don't want to do anything that's going to kill the baby. And sometimes with a PPROM, the water bag will really seal up and it'll start gaining fluid. So in my practice so far, I've seen pretty much about everything happen, but luckily I've never had to do anything that's compromised a baby's life. But this is an issue you hear a lot, again, with ACOG and with my OBGYN colleagues. Oh, she's ruptured. We need to put her out. She can't stay pregnant. And so I've had colleagues where they've transferred the babies to Iowa City and the moms have gone through that. And the psychological sequelae from there has just been terrible because they keep wondering, what if? What if I'd been given the chance? Did I have to do this? And I always tell my patients too, we're not God. I mean, I can give you the best information possible. It's ultimately your decision, but I don't have that crystal ball. I don't always know how things are going to turn out. Fetus incompatible with life. So we've got Linda Ruby here from Women's Choice Center, but we also, through Trinity, have what's called a perinatal hospice program, which I don't know, did you know we have perinatal hospice? You didn't know that. It's actually pretty cool. So what perinatal hospice is where if a lady is pregnant with a baby and the baby is basically incompatible with life, meaning it's going to die either during pregnancy or shortly after. I can't tell you a time frame. It was going to die in the first couple hours. It was going to be a couple weeks. We don't necessarily know, but we know baby's not going to live for very long. And that would be like an anencephalic baby where the brain's not completely formed. So there's a handful of diagnoses that pretty much everybody agrees this baby is not going to live. ACOG, again, usually promotes that, well, baby's not going to live, so why don't we offer the mom a termination so that way she doesn't have to go through pregnancy, and it's healthier for her because it's too stressful to go through pregnancy. Well, I would respectfully disagree that that is probably the worst thing to do. She has a child. Taking that child early is going to be hard. Psychologically, they do terrible. There was a program, it's called Perinatal Hospice, was developed back on the West Coast, Byron Calhoun back, I think it was at 93 or 94. It's been quite a long time. Anyway, so what we do is we love the mom and the baby for where they're at. So we provide supportive care, frequent ultrasounds, bonding. We help that mom trying to come up with funeral arrangements, let her have as much bonding on the ultrasounds as she can with the baby so she can spend that time as being a mom, even though she knows baby's not going to live long. And then we do supportive care after baby's born. So, when they come out, if they don't have much of a brain, a nice hat that covers it up, where I had one that we did perinatal hospice on a couple years ago, that all the insides were all on the outside. So at the time of delivery, it was a C-section, we used one of the limb sleeves that they use for orthopedic surgery. We put baby in this little sack that was all sterile, but it was appropriate for surgery. So mom got baby in a bag. It was, I'm trying to make light of it, but it was really sweet. So she got to see baby without seeing how all the bad stuff with baby. So we're kind of loving them where they're at and being supportive. And so there has been some really good studies that moms that go through perinatal hospice, even though it is a hard pregnancy. I mean, everybody does want a perfect baby. It is a hard pregnancy. I'm not going to say it's not. But they just do so much better psychologically. And they know that they love their baby for where the baby's at. And then we're supporting them. So when I trained in residency, if you had a baby like that, well, at no point to see her, we can't do anything for her. Well, that's not the right thing. They need your love. They need our support. So it's just, again, with Catholic healthcare, let's meet them where they're at. Let's do the support and do the loving, compassionate care that we can. So, and where else was I on that? Sorry.
Dr. Bladel, I had a situation whereby we worked with...
Did you hear he called me Dr. Bladel? Has anybody heard that in a while? That was my maiden name. Sorry, I'm on senior radio. I've known him since I was Bladel. Anyway, go ahead.
We had a great couple who we worked with. She had an encephalic child, and she and her husband were there, and we did the baptism right after the birth of the child.
Okay.
So, quite spiritually beautiful.
Yeah, that would be. And of course, you guys all know that in the middle of a C-section, if baby's going to die, as a healthcare provider, I can baptize if I think baby is going to die right away. And we actually had Father Charles in for a C-section once. We don't tell that story. That's a fun story.
Baby was fine.
Baby was fine, but that was something. It was a transfer of care, so I didn't know the mom very well, but did not have. There were some issues, and we weren't able to resolve any of that before the C-section. So I didn't know, is this baby going to live or not, because we didn't have all the information. And
probably last time you'll ever see me in delivery.
But it was fun, but it turned out to be, again, that was another indication that, with OB care, you don't always know all the answers. And so anyway, surrogacy, this is another heartbreaking issue, surrogacy. When couples are infertile, babies have now become like a material good or commodity, where if I want a baby and I don't have a uterus, I don't have the ovaries, or my husband doesn't have a sperm, you can have egg from somebody, sperm from somebody else, and somebody else can carry the baby, and then a different couple can raise a baby. It gets confusing. It gets really confusing. So people will call the office and say, well, I'm a surrogate and I'm carrying a pregnancy. I actually do not care for those ladies. If they're an established patient already, I will still take care of them. It is really hard. And it's hard for the mom. And even though it's nice for them to make $20,000 or $30,000, because it is really a business transaction for renting their uterus, but it's hard emotionally because she's still bonding with the baby. And so we do have couples throughout the world actually will pay for women to carry their baby. And for whatever reason, Illinois is a friendly state for that. This area is friendly because there's less paperwork. So we actually do take care of quite a few surrogates. I know I've had colleagues that have had gay couples from Spain that have they've had the baby here because it's been a friendly area. I just say, why I've got this on here, it's just an example of how crazy our culture has been that babies, it's not so much about husband, wife, sperm, egg, making a baby naturally. It's now a kind of big business, so anyway. And then also a big issue with obstetric tubal ligation with cesarean section. I do have patients that I've seen for years, they'll say, well, I have a C-section, I want my tubes tied. They all know where I'm at. They know I'm not going to do their tubal. I do try to talk them out of it. And one of the common things I'll say is, what happens if baby dies 2 days later? Do you still want your tubes tied? And a lot of times the tubal ligation at time C-section is a convenient surgery. They're opened up. They want convenience. They don't have to come back in for surgery. But you have to really think about long term. You're pregnant. Are you hormonal? Are you really at the place to make a decision that's going to be life altering for you and your husband? Is this something that you want to make that decision at that time? So I really do encourage, if they really want that done, to wait and not do it at that time. But if something happens to baby, you never know. And we've all had situations where when we'll get her tubes tied, and then 5 years later, either her husband dies, she gets remarried, something happens when the kids, she wants to have babies again and do a tubal reversal, which we can do, is really expensive. It can be anywhere from $20,000, doesn't always work, and then that regret. And so there's been even a lot of studies through our medical literature, somebody gets a tubal ligation, especially if they're in their 20s, the amount of regret is pretty significant. So I really do try to talk to somebody, even if they want one done, to really consider not doing it and wait till they're in a better state of mind to make a life-altering decision, because it can be life-altering. Also with that, ACOG will always say, well, the more C-sections you have, there's a higher risk. And of course, it's true with everything in medicine, there's always more risk. And granted, there is a risk for placenta previa, placenta accreta, but I've also had C-sections where I've done a lady 6th, 7th, 8th C-section, and the body's miraculous. It will always heal up. And yeah, things get a little bit more complicated, but that's the beauty of American medicine. We can handle the complications. So we let them know what the risks are, that there are risks involved, but we can also manage it. So I've had people say, well, my previous doctor said after 3 sections I have to get my tubes tied because it's not safe for my uterus. Oh, really? Based on what? Yeah, there are risks, and we'll talk about it, but I tend to get really frustrated with some of my colleagues with that paternalistic attitude that you've had your 2 babies, you're done, or you've had your 3rd section, you're done. And I think it's very easy for OBGYNs to kind of fall into that how many babies are too many. And that's really not our decision as a healthcare provider. That's the couple's decision to be making. So anyway, on that. So gynecology, same thing on healthcare, tubal ligation, which I kind of talked about the C-section. So the big push again with ACOG is what's called LARC, long-acting reversible contraception. So Dr. McDivitt is like, wow, all these things have changed so much. So there's a big push. Of course, IUDs were available when you were training, but I'm trying to remember what it was when we were training. But now it's Nexplanon, and there's all these big push for long-acting. And so ACOG is just sent out a note to all members on how to push your hospital administrators to make all this available, that all young ladies coming in having a baby, that this should be the standard of care. They should automatically get this. Seriously, when are we that paternalistic that we are demanding for these young girls that they can't have any more babies, that we are going to put this in right away? So actually the ACOG, and I just got this on my phone last week, I was shocked when I'm reading that we will come out and help you institute this program because this needs to be made readily available and as easy for these young girls as possible. We talked earlier about oral contraceptive pill, how it worked, and when does life start, so there's issues with that. Gender surgery. So I'm sure, Dr. McDivitt, you probably never had anybody ask you to make a girl into a boy, did you? No. So believe it or not, I've had that come up a couple of times, I know, where patients would come in and say, Doc, I'm really not a girl anymore, and I need to be a boy, and I need to have this done. And I respectfully will decline and tell them, the beauty of, of who they are as a human being. And it's really some complicated conversations. And I spend as much time as I can with my patients and trying to meet them where they're at. But once they make that decision, they go that route, it's permanent, it's forever. And there's all sorts of stuff in the medical literature on what are we doing to these people, and are they really okay up here? Are we really doing a good enough psychological evaluation? And there are clinics. Unfortunately, a friend of mine actually is running a clinic that does that in San Francisco, and it's kind of, again, becoming a big business on doing gender changing surgery, and she's becoming he's, and I guess go off another patient story. It'll be the last patient story. I had a couple that, a lesbian couple, and the one partner had gotten pregnant the old-fashioned way, but it was because it was cheaper than going to a clinic. So they're raising the baby, and then they come back in 2 years later, and the one, she decides that she wants to be a he, and so now the couple's not going to stay together because they're not really a lesbian couple because of one's a girl, but now one's being a boy. And it was like, oh my gosh, my head hurt trying to talk to them to figure out what's going on. But then there's this child. So this young child that's growing up in the situation of who's mom, who's dad, and where are we at with stuff. So, I think culturally we need to really take a step back and try to do what's best for our children. Reproductive infertility, non-traditional childbearing, that goes with surrogacy, infertility. Time-wise, I won't really hit that too much. Again, emergency medicine, I'm not an ER doc. There are, issues. Somebody comes in raped if they're not already on contraceptive stuff, they've not been sterilized. How do we treat with giving morning after pill? And we want to make sure that's not at the time of ovulation. We don't want to prevent her to go through an early termination. There's a thing called the Peoria Protocol that some hospitals are utilizing. I believe ours has been in the past. I'm not sure what we're doing right now. But again, that's another issue with OB. So what do I offer? Since I'm not doing all these other services my colleagues are doing, we offer what's called natural family planning. And what natural family planning is basically teaching the woman how to learn how her body works. It's just basic education. Good analogy I use for our diabetics, we teach them how to eat a healthy diet. Their proteins and their carbs and their fats. With NFP, we're teaching them just basic healthcare and how their female system works. So there's different ways. There's the temperature and mucus method. Two organizations, Couple League and Creighton method, where you can see the chart up in the corner. Well, no, that's the Billings chart up in the corner. Anyway, the charting is with the temperature and with the mucus. A little bit more time intensive. In our office, we teach what's called Billings ovulation method. It's easier in office-based practice where we have women learn how their fertility works. Marquette has a oh my gosh, I'm talking too much. A urinary metabolite where there's a clear blue, it's a fertility monitor. So for people that have a hard time knowing their mucus, knowing their temperature signs, and need more of a tech way of knowing their fertility, Annie, my physician assistant, is getting certified in the Marquette method, so we're able to offer that now. Georgetown cycle beads, the rhythm method doesn't exist. This is probably the closest thing to the rhythm method, though, is where somebody's pretty regular and they can use these cycle beads. So that's used in a lot of third world countries. So it's nice to offer, and the nice thing with NFP, it's not just about helping people not get pregnant, it's about helping them achieve fertility. I can't tell you how many times we've had couples come in that they had no idea how to tell their fertility. We've been able to help them get pregnant without drugs, without devices, by just basic education. So in Magnos, we had this really nice Indian couple. Didn't speak real good English, but we were able to work with them. And they've now gone back to India. But they were so excited. You would not believe the gifts they brought to the office because nobody told them how their body worked. They had struggled with infertility for 2 or 3 years. And after meeting with Maggie, we were able to get pregnant. And oh my gosh, it was really sweet. So it's nice that we can offer that. And the other thing, and this goes back with Catholic healthcare too, I mean, the child is a blessing from God, and it's from mom and dad getting together and just celebrating that. I mean, kids aren't a commodity, and I guess going back to all the OBGYN, we really need to treat the family as a whole, and that's the beauty of NFP, it is really treating the family as a whole. So other things, especially in a hospital, ethics panel of always, if there's something that we're not sure of what's going on, what's the best way, we do have ethics counsel, which is always available. And again, in the mindset, kids are not a commodity. Healthcare is not a commodity. We're not, I guess culturally we become more of a commodity, but it's, are my physician or my provider? Is the patient what they want? Do we do everything the patient wants? Do we have to look at what's really best for them as a whole family unit, as for their kids and for their family and their marriage situation? Interesting on statistics, couples that use NFP have, I think, less than a 5% divorce rate because it makes the husband being more intimately involved, that when she's fertile and they agree at the time that they're not going to have a baby, then he has to abstain. So it's that communication between the couple. So there are some beautiful NFP, which this talk wasn't about that we can offer that culturally just makes a big difference. So if that's for solution, resources, and then on the next page is, so those are resources. Actually under facts, our third bullet down is a group. Maggie, are they on the East Coast? I think. Where's Margaret Joyne? DC. Yeah, so Maggie's one of their speakers. Anyway, it's a family practice doc that's got this great collaborative, and we're one of their research centers for facts program through our office on just teaching NFP and the different resources that are available.
So through them, you can go to medical school and get a 1-credit course.
So you get CME credit for that, and then also for medical schools too.
So it's kind of getting the news out through the docs.
Yeah.
In training.
And then also for available resources, the Catholic Directives, ERDs, I think it was volume 6, my senior was telling me on that. So that would be another resource available. And then the references. Well, thanks I know we had some extra guests from the hospital. Thanks you guys for coming and listening. I appreciate it. And thank you guys very much.